Hello everyone, my name is Lin Fan and I'm from Provincial Clinical Medical College of Fujian Medical University. In the physical examination section, you should master the basic techniques of physical examination, be familiar with the clinical significance of normal and abnormal signs, and understand how to exercise the methods of inspection, palpation, percussion, and auscultation during clinical practice. In this lesson, we'll learn about palpation and percussion. Palpation is the use of touch to determine the characteristics of an area of the body, such as skin elevation or depression, warmth, tenderness, pulses, characters, and sizes of organs or masses. We touch the patient with different parts of our hands, using varying degrees of pressure. Because the hands are our tools, make sure to keep our fingernails short and our hands warm. Sometimes we need to wear gloves when palpating mucous membranes or areas in contact with body fluids. When we lay our hands on the patient, we perceive physical signs by tactile sense, temperature sense, and the kinesthetic senses of position and vibration. The tips of the fingers are most sensitive for fine tactile discrimination. We use the dorsal of the hands or fingers to feel the temperature sense. The skin is much thinner than elsewhere on the hand. Palpate with plasma aspects of the metacarpophalangeal joints on the underside of the hand rather than with the fingertips to perceive vibrations such as thrills. Palpation is employed on every part of the body accessible to the examining fingers. All external structures, all structures accessible through the body orifices, bones, joints, muscles, superficial arteries, and so on. Specific qualities elicited by palpation are summarized as follows, such as texture, moisture, elasticity, pulsation, skin temperature, and characteristics of masses. For example, the surface characteristics of the skin and hair are noted. Are they brittle, coarse, thick, thin, roughened, or smooth? When a mass or enlarged organ is discovered, record its size, shape, consistency, mobility, surface regularity, and the presence or absence of expansile or transmitted pulsation. During examination of the bones, joints, pleural, and subcutaneous tissue, note palpation. These figures show palpation of the precordium for signs of heart action. Speech creates vibrations that can be heard when the examiner listens to the chest and wall. These vibrations are termed vocal frequencies, which can be felt. Pressing the under aspects of both hands firmly against either side of the chest, while the patient says the words 99. This maneuver is repeated until the entire posterior thorax is covered. The bony aspects of the hands are used as they are particularly sensitive for detecting these vibrations. Methods of palpation include light palpation, deep palpation, and bimanual palpation. We always begin palpation with a light touch. Our sense of touch is most acute when lightly applied and the patient will be put at ease. Gently sliding our fingertips over the skin surface will often detect subtle or mobile masses that are undetected by forceful palpation. Depress the skin 1 to 2 centimeters with our finger pads, using the lightest touch possible. We will also locate areas of particular tenderness, which should be examined last. For example, palpating anterior cervical lymph nodes. The figures show the palpation of the thyroid. Pressing and holding the finger into the swollen tissue of a bony area for 5 seconds. If there is an indentation left behind when we remove our fingers, it is referred to as pitting edema. Firm pressure is applied to display the superficial tissues, allowing palpation for deeper lesions. This is especially useful in the abdomen, but is also useful in the neck, breasts, and large muscle masses. Avoid firm palpation over nerves or other tender structures whenever possible. Depress the skin 4 to 5 centimeters with firm, deep pressure. We may use one hand on top of the other to exert firmer pressure if needed. These two pictures compare light and deep palpation. Bimanual palpation. In this technique, the tissue is examined between the fingers of the two hands. It's useful for softer tissues such as the breasts, intraoral, abdominal, and pelvic examinations and examination of the muscles and joints. These two pictures show the bimanual palpation of the kidneys. The figure shows the bimanual palpation of the liver. Okay, that's all for the palpation. Let's move on to the percussion. When the body surface is struck, the underlying tissues vibrate to produce percussion notes having mixed frequencies that vary with the density of the organ, the composition of the lying tissue, and the force of the blow. When we elicit sound by striking the body surface directly with our fingers, hand, or reflex hammer, the procedure is called direct percussion. Striking the percussion blow on our fingers is indirect percussion, which is the form of percussion most commonly used. Press the distal part of the middle finger of our non-dominant hand firmly on the body part. Keep the rest of the hands off the body surface. Using the middle finger of the dominant hand, tapped quickly and directly over the point where the other middle finger touches the patient's skin. Listen to the sounds produced. Percussion notes from tissue of high density to that of low density are summarized as follows. For example, percussion of a large muscle mass, such as the thigh, produces a fret note. Percussion of a solid organ, such as the liver or heart not covered by lung, produces a dull, low amplitude, short duration note without resonance. Percussion of a structure containing air within a tissue, such as the lung, produces a resonant, higher amplitude, lower pitched note. The chest percussion. The sides on the posterior chest for percussion are above, between, and below the scapulae in the intercostal spaces. Let's watch a short video on palpation and percussion of the lungs.
The next thing I'm going to do is palpate his chest. This is just palpating for any subcutaneous air trapping and also tactile phlegmatis, I'm going to use the palmar aspect of my hand and place it in his intercostal muscles and have him say 99.
99, 99, 99, 99, 99, 99.
Tactile phlegmatis is the vibrations of his words coming through, and you should normally feel those, and they should be symmetrical from side to side. So it's more important to compare one side to the next side, especially when you're dealing with the lung and thorax. The fact that it's present is not as interesting or significant as if it's present and symmetrical between both sides. So I'm first palpating the back. I'm palpating for any tenderness, any pain, and just looking that the structures are symmetrical. But similar as I did on the front side, I'm going to be checking for tactile phlegmatis. Can you say 99?
99, 99, 99, 99, 99. 99.
And you'll note that if you feel over the scapula like I just did, you don't really hear any you don't feel any of the vibrations in your hand. But over the lung fields, you feel good vibrations. And even more importantly or significantly than the fact that you can feel them is that they're the same from side to side. Another part of palpation is to check for lung expansion, for symmetrical lung expansion. So I'm going to put my hands around the 10th rib and span my hands out laterally over his ribs. And then with my thumbs close to his spine, I'm going to actually push them medially so that I get a little bit of the skin there so I can watch it expand. So go ahead and take a deep breath in, Makana. And as he takes a deep breath in, my thumbs go with him. And you can see that the thumbs expanded together, that one side didn't go up and the other side stayed the same. They should equally go up and equally fall back down. That's chest expansion. And then next, after that, we're going to percuss his lung fields. You can do this on the anterior side also. It's a little bit harder because of the musculature of the anterior chest wall and the breast tissue in female. So, but percussion, you want to stay away from the scapula because obviously that's going to be a dull sound. But percussion, again, with your non-dominant hand, you place it on the area you would like to percuss. I use my middle finger. And then with your dominant hand, middle finger, you strike the DIP joint of your non-dominant hand and then release. So it's a quick tap, tap, and release so that you don't muffle the sound. So. And it should be a nice resonant sound because the lungs are filled with air. If you palpate over a rib, then you're going to get that dullness because it's going to be a dull, bony sound. So you want to palpate in between the ribs and the intercostal muscles. And so you'll percuss down, map the borders of the lungs, get an idea of where the lung tissue ends. The next step then is to do a test that we call diaphragmatic excursion. It maps out the diaphragm's movement during full inspiration and full expiration. So I'm going to have Makana take a deep inhale and hold it. While he's doing that, I'm going to percuss down and mark the area where it changes from resonance to dullness. So it's right there. So if I had a pen, I would mark right there. Now I would do the same thing on this side. I would mark right there. Go ahead and exhale. Okay, and then take a deep breath, and then exhale it out and hold your exhale. So once he's completely exhaled, I would start over again. You can either start from here and percuss down, or you can start from down here and percuss up to where it sounds from dull to resonance. And then you mark that area. You do the same thing on the opposite side, and they should be equal from side to side. And you mark how the change of where the resonance and dullness is. And this change here is the diaphragmatic excursion. It's the amount that the diaphragm moves during inspiration and expiration. That should normally be between 3 and 6 centimeters. And someone who's well-conditioned, a well-conditioned athlete whose lungs are really in shape, they can sometimes get up to 7 and even 8 centimeters.
Percussion of the heart is employed to locate its boundaries with the lung. Let's watch a video of cardiac percussion.
So the heart is in this area, and so what we're going to find out is the areas around here will be nice and resonant where it's lung space and airspace. But when I hit the heart, it's going to change to dull. So we can basically start and do any rib space, do second intercostal space, and start mid-anterior axillary line. And there's my spot. It changes from resonant to dull. I can go to the next interspace down. There it is. So I could actually make dots the whole way along and mark it, and I would actually have the outline of the lateral border of the heart. And the one that's the most important is the fifth intercostal space, because the fifth intercostal space is where the mitral valve is, which is the left ventricle. And if any of the chambers of the heart will enlarge, it will be the left ventricle. So for this one, which is the most important, you want to start at the mid-clavicular line, mid-axillary line. And you can hear the sound change right there. I've hit the left ventricle, the apex of the left ventricle. You can also make sure that the heart hasn't shifted to the right-hand side by coming along and making sure the whole right-hand side is resonant. On a female, really the only rib space you can do is the fifth rib space coming across. And again, on a female, you would ask her to take her right hand, cup her breast up, her arm will be out of the way, and you can just slide like right along here along the contour of the pec muscle. And that concludes the percussion of the heart.
Percussion of the abdomen is used to demonstrate the presence of gaseous distension and fluid or solid masses. In the normal examination, usually only the size and location of the liver and spleen can be determined. The upper border of the liver is percussed in the right mid-clavicular line, starting in the mid-chest. As the chest is percussed downward, the resonant note of the chest becomes down as the liver is reached. As percussion continues still further, this down note becomes tympanic because the percussion is now over the colon. Here is a video of liver percussion.
Percuss the span of the liver. First, locate the mid-clavicular line. Use a light to moderate percussion strike. Starting at a level below the umbilicus in the right lower quadrant, in an area of tympany, percuss up toward the liver. Identify the lower border of dullness in the mid-clavicular line. Next, identify the upper border of liver dullness. Starting at the nipple line, lightly percuss from lung resonance down toward liver dullness. Measure the span of liver dullness between those 2 points. The normal liver span in men is shown here, and it is generally greater in men than in women.
Testing for shifting dullness. A special percussion test may be performed. Here is a video of testing for shifting dullness.
With practice, you will also be able to utilize special techniques for assessing possible ascites, including percussing outward in several directions from the central area of tympany. 2 additional techniques are testing for shifting dullness, percussing the border of tympany and dullness with the patient supine, then turning the patient onto one side and percussing again, and testing for a fluid wave by tapping one flank sharply with your fingertips while you feel on the opposite flank for an impulse transmitted through the fat. Individuals with more body fat will need 2 sets of hands for this test.
Kidney percussion. Press the ball of one hand in a costovertebral angle and strike it with the under surface of our fist. Use enough force to cause a perceptible but painless thud. Okay, that's all for this lesson. These are recommended reference books for further reading. Here is my email address. Feel free to contact me if you have any questions. Thanks for watching and goodbye.